Okay, so that Mother's Day slide really makes me look bad, so thank you, Chris, but I'd like to let everyone know that I will call my mom after I'm done talking. This is a retroactive outline. Thankfully, Dr. Venner already showed one, and this looks pretty similar, but Dr. Venner has spoken about the new proteasome inhibitors. Of course, proteasome inhibitors as a category of drug have been around for quite some time now and are somewhat old news. Now we're going to move on to the really new and exciting stuff, which are the monoclonal antibodies and a new drug called selinexor. This, in a way, sort of gets to the conclusion first. This, I think, is a fairly uncontroversial slide showing what are now, at least from a Canadian perspective, what we would consider the major established drugs in multiple myeloma. And the first four are really uncontroversial. These are the ones that have been established for some time. You have what we call the alkylating agents and corticosteroids, which have been around for many decades. More recently, there have been the proteasome inhibitors and these so-called immunomodulatory drugs, which we've been using for over a decade. And the new arrival is what I'll be focusing on mainly in this talk. You can argue about whether it's truly established yet, because we're not using it routinely yet anywhere in Canada. But I think there's a very strong expectation that it will be soon. And these are the monoclonal antibodies, above all, a drug called Daratumumab. Now, I assume, or I suspect that in the audience there are going to be some who are quite savvy about some of these new drugs, but I don't want to make any assumptions, and we're going to try to keep it fairly general, just to give you a good general understanding of these drugs, also because I've been told that I only have 10 minutes left to speak. So first, monoclonal antibodies. So monoclonal antibodies have been used in oncology for quite some time now, and it's a category of drug that's shown success in treating different types of tumors, for example, lymphoma, breast cancer. But it's taken us some time to find a good monoclonal antibody for multiple myeloma, which is interesting because if you look at how monoclonal antibodies were first developed, it was actually with the use in the lab of multiple myeloma cells. And this just shows the principle of monoclonal antibodies and how you produce them. So normally, in the normal human body, you have different populations of immune cells that are producing antibodies against different targets that we refer to as antigens. The principle with monoclonal antibodies is that in the lab, you have a single population of immune cells that you're using to produce a single population of antibodies, all directed against the same target. And the idea in oncology is that you create an antibody targeting a particular antigen on the cancer cell. So historically, or at least initially, this was done in the lab with the use of mice. So what you do is that you give the antigen, you inject the antigen into the mice, into the mouse. The mouse would produce the immune cells that then had the antibodies against this antigen. You would actually combine the antibody cells with a myeloma cell, and you'd produce a fusion cell called a hybridoma, and then you'd multiply these cells and then produce large amounts or manufacture large amounts of these, again, monoclonal antibodies, all directed against a single target. Even though the mouse was really the initial platform, things have developed over time, and with the use of newer DNA techniques, newer monoclonal antibodies have been produced, which either represent combinations of mouse and human DNA or entirely now human DNA as well. This is gives a general representation of how antibodies work against cancer cells, or monoclonal antibodies work against cancer cells. And the main point here is that what happens is that the antibodies will attach or bind to the antigens on the target myeloma cell, but they don't work alone. What they do is that they recruit other cells and other molecules, which are then used to attack and kill the myeloma cell. So for example, you have an antibody here attaching to an antigen and recruiting something called a natural killer cell. Or you have an antibody here attaching to an antigen and recruiting something called a macrophage. Or you have an antibody here attaching to an antigen and recruiting something called complement, all of which can be used to kill, in this case, the myeloma cell. And different monoclonal antibodies can use these different so-called pathways to different degrees, and that's what can distinguish the activity of some of these different antibodies. As I mentioned, the monoclonal antibody that's furthest along in development in multiple myeloma is a drug called Daratumumab, which is a fully human monoclonal antibody, no mouse component. And it's an antibody that targets, and this is really the molecule or the antigen that's been the most that's been the most promising target for monoclonal antibodies in multiple myeloma. And it's a molecule on the surface of myeloma cells called CD38. And one of the things that makes this a desirable or an attractive target for monoclonal antibodies in myeloma is that it's present on virtually all myeloma cells, but that it's present to a much lesser degree on other cells or other normal cells in the human body. It is present to some extent on other blood cells, but at lower levels, and even to a lesser degree on other normal cells in the human body, such that really the effect seems to be the effect of the drug is directed mainly at the myeloma cells, with less in the way of collateral damage against other normal cells. It's an intravenous drug. It is given on a somewhat, at least initially, cumbersome infusion schedule. So it's an intravenous drug that's given initially on a weekly basis for the first 2 months of therapy, and then gradually becomes less frequent, so that it's given every 2 weeks for the next 4 months, and then on a monthly basis, essentially indefinitely after that, as long as it keeps working. And because it's a targeted drug, it really, especially if you give it on its own, is a very well-tolerated drug, aside from the challenges of the infusion schedule. Really, the main side effect is what would be described as allergic-type reactions, which occur primarily during the first infusion of the drug and then much less common afterwards. And I'll come back to those in a moment. What we have seen is that it's a very effective drug. It was first tested on its own, and it was tested in patients who had relapsed myeloma, who had already received a number of previous treatments. And even in these patients, you still see that approximately a third of patients had a response to the drug, which is quite good when you consider the number of previous treatments that they've received. But as with some of the other drugs that have already been mentioned, because this drug on its own is quite well tolerated, it's quite an attractive drug to try combining with other drugs. And above all, we've seen success when it's been combined with lenalidomide in a regimen referred to as DRD, and with bortezomib in a regimen known as DVD. Probably the biggest success we've seen was a trial looking at the combination of daratumumab with lenalidomide and dexamethasone, a trial referred to as the POLLUX study. These were patients with relapsed myeloma, and the approach of the trial was similar to some of the trials that Dr. Venner has already described. And in this trial, patients in this study who also had what we call relapsed myeloma, patients would receive either just lenalidomide and dexamethasone or lenalidomide and dexamethasone with daratumumab. And a comparison was made between these two groups. And what they saw, and these are the results that we now have after 2 years of following patients on the trial. So we look at a measure called progression-free survival, which is essentially tells us how many patients still have their disease under control at a certain point of time. So after 2 years on the study, if you look at the patients who were receiving the daratumumab with the lenalidomide, 70% of the patients in the study still had their disease under control, whereas only 40% of patients who were just getting lenalidomide had their disease under control. So a significant improvement in control of the myeloma if you add the daratumumab in. So again, looking at the challenges and side effects, primarily it's what we refer to as infusional or allergic type reactions, which typically occur during the first infusion of the drug. And that it's probably about, at least in the initial reports, about 40 to 50% of patients where that happened, though in the majority of cases, these were fairly mild reactions and could be generally managed by slowing the infusion down or by giving other medications like Tylenol or antihistamines to control the symptoms. And in fact, in more recent experience, I think we would say the general observation has been that these reactions have become even less frequent. A lot of that has to do with the fact that we're now using it together with dexamethasone, which by itself tends to mitigate infusional reactions. Typical symptoms: people can get some nasal congestion, irritation of the throat, cough, chills, nausea. Some people can get shortness of breath. That seems to be more of an issue in people who have a history of asthma or emphysema, where some caution is required. Unfortunately, though, in order to reduce the likelihood of these reactions, this drug is still given quite slowly, so that the first infusion is given over 6 to 7 hours, but even after that, indefinitely, it's given over 3 to 4 hours. What's being worked on is a formulation of the drug to be given under the skin, which will obviously be much more convenient, and that's currently in clinical trials. Dr. Venner has already spoken about some of the principles of drug availability. Where do things stand with daratumumab? So I think you guys probably have some familiarity, or there's already been some discussion about the distinctions between regulatory approval and funding approval. As a single agent, unfortunately, although it was approved by Health Canada, it was not judged to be good enough or effective enough to have a recommendation for funding by the P-coder body. However, in combination with other drugs, specifically lenalidomide and bortezomib, P-coder did give a favorable recommendation. The way it was worded was that funding was recommended conditional upon an arrival at a satisfactory price, which is kind of like going into a bazaar and saying, I'm going to buy this, but only if we get the price down by about 80%. But generally, the idea is often when that recommendation is made, there's often, based on previous experience, an expectation that eventually a funding agreement will be reached. And there are ongoing clinical trials with daratumumab, including one that's currently being run through the Myeloma Canada Research Network called the Laurentian study, where it's being looked at together with pomalidomide and cyclophosphamide. I'm going to make this my last slide just because I see that time is running out. And this is just to say that there are other monoclonal antibodies under development. The other one that's furthest along is a drug called Isatuximab, which also targets the molecule CD38. It binds to a different epitope of CD38, which means a different component of the molecule of CD38 than daratumumab does. So far, we only have early phase clinical trials, and we're still awaiting the results of larger trials. So it hasn't been approved by any of the regulatory bodies yet. What we've seen so far in the early trials is that at least the response rates or the effectiveness seems fairly similar to that of daratumumab. What's a little less clear at this point is what advantages it has to offer over daratumumab. And this is, I think, a phenomenon that we have to be sort of cautious about increasingly in oncology, which is that now when you have one drug that's shown in a category to be effective, you see increasingly a large number of other drugs come along in the same category. And and in many cases, it's unclear what there is to distinguish between the different drugs in terms of their advantages. At least preliminarily, there's some suggestion that the rate of infusion reactions is lower, and that it might be possible to give this drug over shorter infusion times, but that I think still remains to be clearly established. And again, following on the idea that these are drugs that are of a similar category and have similar modes of action, I think it has to be recognized that And this is the same with other categories of drugs, that when you have drugs that work the similar way, it's quite likely that there's going to be something called some degree of cross-resistance between the drugs, which means that when one drug stops working and you try using another drug in that same category, it might not necessarily be effective, or at least as effective as it would otherwise have been if you had used it at the start. This is likely to exist between Daratumumab and Isatuximab, and what it means is that although at least there's a temptation to want to use all drugs that we have, all drugs that are available, there may be some limitations in terms of some drugs no longer being effective if you have used a previous drug from the same category. Again, in the interest of time, I think I'm going to stop there, and I think we'll put the questions off until afterwards as well.
Leave you the questions. Thank you.